Okay, minimize that. Got it. We are now live on Facebook. Our participants are starting to join the room, and I welcome everybody. It is November 10th, 2022. Depending upon where you are in the world, it's either 5 o'clock Central Time or 6 o'clock Eastern Time. I am coming to you from Dallas, Texas tonight, where I was doing a project earlier today. If in the event that I have hotel internet problems, Julie or Stacy from the HCMA team will be taking over the helm and helping us out. If you are watching on Facebook, you are able to view this session. Julie and or Stacy, could one of you please, because I don't have access to all my monitors here tonight, can you put the joining information to the webinar in the Facebook stream so that they have it there as well on Facebook? If you're watching on Facebook, we're not taking questions from Facebook. If you are in the webinar with us, you'll have the opportunity to ask and answer questions by using the Q&A tab at the bottom of your Zoom screen. Please do not use the chat feature. It's very hard for us to track the questions through chat, so you can use the Q&A. I'm going to launch a poll right now, and over the next couple of minutes, you can all take part in the poll and let us know where you're coming to us from and what your position is right now within the HCM spectrum. Are you making decisions about a treatment option? Are you newly diagnosed? Are you considering surgery, ICD, starting a new medication, etc.? You can put those in the bottom. That just lets us help to create content in the future and answer questions that are important to you. So for those of you who don't know, I am Lisa Salberg, founder and CEO of the HCMA, and I'm really happy to be with you tonight. And from my staff, I have Stacy Titus, our Center of Excellence coordinator, and Julie Russo, our volunteer coordinator. Tonight we are proud to have our HCMA recognized Center of Excellence, Westchester Medical Center, and their director, Dr. Naidu, here with members of his team. Good evening. How are you today?
We're great. We're looking forward to this. So thank you for the invitation. Should be a nice,
absolutely.
Nice.
Can you introduce us to your team?
Yeah, I'm going to put up a slide just to go over a little bit. All right. So again, thank you for having us here. We've been looking forward to this, an opportunity to showcase our program here at Westchester Medical Center. I'm going to start just 2 slides. One is introducing the team, but the first one is just going to be a little overview of some of the aspects that we think are unique to our program, and hopefully we'll end at the end with the really unique part, which is our team, to talk about what makes us special, I believe. But our program was originally established in 2006. It was originally the Cornell NYP program, became the NYU Winter program. And then Dr. Panza, who is here tonight with us, our chief of cardiology, director of cardiology, recruited us to Westchester Medical Center in 2016. So we became a new center of excellence again, or a quote unquote new one again at that point in 2017. But if you take it in totality, one of the oldest programs in the country, I'm very proud of that, with stable leadership. We now see or have had over 2,000 active patients followed and treated. And I think one of the unique aspects is that unlike other programs that people come to from far away and then go back, we have a large catchment area. So a lot of people, I'd say over 90–95% of our patients are coming here and continue to have their follow-up here, which gives us a unique advantage to really see them longitudinally to make sure that we're following really all aspects with the referring cardiologist. We do have 2 offices in different locations, about an hour apart, Westchester and Long Island, with all full complementary services, including echo and all the ancillary technical support. And that is a testament, I think, to Westchester Medical Center understanding that we want to be close to our patients, so it makes it a little easier for them and give them some options. We are the highest volume alcohol ablation center in the country currently. We do between 40 and 50 alcohol ablations a year and about 25 to 30 myectomies a year. We're going to talk more about that later. And one of the nice things is we do have heart transplantation for those patients who qualify, and probably send 2 to 3 patients a year for transplant evaluation. Again, we have the full complement of expertise. I think we recently hired a new pediatric surgeon for pediatric myectomy. We obviously do pediatric ICDs and CPETs and all kinds of therapies for kids. But we also have the full surgical support. Dr. Malekan is here today, and we'll talk about both the subaortic myectomy and the apical myectomy that we're doing here as well. obviously the advanced imaging, genetics, psychiatry, social nutrition, other support as well. We're also been involved in the clinical trials. I'll talk about that briefly in a subsequent section. And finally, we do publish the main textbook in HCM now in the second edition. So I think you've seen this. This is the only other slide just to introduce people from our team. Obviously, I'm the director of the program. Dr. Panza is the chief of cardiology. He's going to take you through an interesting talk about the evolution and evaluation of HCM. And his vantage point is that he was, and he'll probably explain to you that he was working at the NIH when a lot of this was really coming into the forefront. So I think there's a unique historical perspective as well as being director of the Echo Lab there. So he can talk us through some of the obstruction areas. Then I'll go through evaluating and managing the obstructive patient. How do we decide how to treat these patients? What do we use to treat them? And a little bit about alcohol ablation, primarily followed by Dr. Malekan, who's here as one of our two surgery teams to talk about the myectomy approaches. Dr. Jacobson is one of the director of complex arrhythmias here, and he will talk about AFib and ICD management in these patients. And then finally, I think a good treat for my team here, we have two coordinators and a nurse practitioner, and they're going to take us through a little bit more of, what makes this place special, which I really do think is the people. And it's the fact that we, I think, really try hard to make patients feel at home. And hopefully that'll be conveyed in that last section. So I'm going to stop sharing.
Okay, and I'm going to start in just a moment here, but I think I love to give a little context as to how long some of us have known each other. I actually first knew Julio Panza as a treating cardiologist when I was a patient at the NIH. And somewhere I have a Rolodex card with his name on it and his phone number from the NIH. I'm going to have to pull that. I didn't throw away my Rolodex. I still have my Rolodex. So I'm going to pull out that card and take a copy of it one day and send it to you.
Yep. And you probably don't have that card, right?
No.
I still have it somewhere. I think it's in the closet in the back of the office. And then I can remember meeting a young, very passionate interventional cardiologist who came to the HCMA booth, I believe it was ACC, and was like, I like HCM, I want to do HCM. And there was just this energy, this ball of energy that I came to know as Hari and Naidu. And that passion has never faded, not for a moment. And I think that is something that Hari and I share, a lot of passion for what we do. So I'm going to do a little bit of a slide presentation right now. And to those who are used to me doing this when I have a big old laptop or my monitors here, that's great, but I'm in a hotel and it's not so easy. So let me pull this up. Give me 1 second. I hope I don't get lost here. And let me go to here. Oh, I can't do that. All right, so I have to do it this way, folks. 1 second. You're going to see a mess on my screen for a second. Share screen over here. And let's put you into present mode. Okay, so there we go. I'm going to be very brief this evening because number one, I'm exhausted. And number two, I want to give the team at Westchester all the time possible. Hari went through the agenda for this evening, so I'm not going to reiterate that, but I will say thank you to our sponsors of the Bighearted Warrior Tour, Boston Scientific, Invitae, Bristol Myers Squibb, and Cytokinetics. We have some new sponsors coming on board, including Tenaya Therapeutics and BioMarin. So you're going to start hearing some new names, people, because there's exciting things happening in HCM, but they just kind of came on recently. So you'll learn more about them soon. So for those of you who aren't familiar, HCMA is a 501c3 nonprofit organization, and we have kind of elevated how we structure our organization, and we work very strongly in the committee structure right now. We've built out our medical affairs. We have other committees that are going to be onboarding over the next 18 to 24 months. Legislative advocacy is up and running. Patient education is up and running. Finance and marketing are coming up next. And we will, and health equity. We're actually hoping to have our first health equity meeting as a committee, hopefully in December. I'm just running out of time and days on the calendar, but I'd like to at least get our inaugural handled in this year. So stay tuned for that. And the committee structure allows us to work in different silos that are very important to HCM. whether we're talking about how to raise awareness and make sure patients understand information given to them, whether we're looking at scientific rigor of how we're managing our data set, whether we're looking at how we're going to change the future by things like the HCM Act. This all starts in our committee structure. If you're interested in volunteering, I encourage you to go to the website and sign up to be a volunteer, and Julie will reach out to you and you can talk about where your passions lie and we can find a good place for you. So who are we and what are we trying to do? Well, our vision has been to be the preeminent organization improving the lives of those with HCM, preventing untimely deaths and advancing global understanding. We do this through a number of ways, and I'm going to kind of go through a couple of those tonight. If you want to hear the whole thing, I've done this talk before in very, very detailed fashion, and you can catch it on another Bighearted Warrior tour. So how we're educating patients and families is variable, and how we're educating medical providers as well. We have our Tales from the Heart podcast, which in season 3, coming up in January, you're going to see probably a lot more faces. We're going to be inviting all of our Center of Excellence programs an opportunity to podcast throughout the year. There may be more than one day of podcasting because we have a lot of people very interested in sharing their thoughts and opinions and perspectives, and we want to give everybody a platform for that. We have the Bighearted Warrior Tour, which you're watching now, and we have the services of the HCMA, our phone lines, our website, our peer-to-peer support, and more. For physician education, we're really excited to announce that the HCM Academy has been afforded funding for next year, and the program is going to change a little bit. Instead of it being small learner groups, it's going to be once a month webinars. They'll be the same webinar, but they'll air twice, once on the European timeline and once on an American timeline, and they'll be the same topics. They will be CME accredited courses, and they're going to kind of focus a little bit more on specific topics of interest in the HCM communities, such as HCM for nurse practitioners or HCM for community cardiologists. And we're hoping that we can, in partnership with all of our centers, get that spoke education. So our centers are the hub. We want them to send it out to the spokes, so those in the referral area know how to help their patients get the high-level HCM Center of Excellence care. So stay tuned for more information on that. Policy and advocacy, hold on to your hats, ladies. Things are about to happen. So our Elizabeth T. McNamee Legislative Advocacy Committee has been working for 3 years to organize something called the Healthy Cardiac Monitoring Act. We took our time to get our data together and to get partners on the team that are really going to help drive this initiative forward. We want every child in America to have the opportunity to be asked about their family heart health history and the opportunity to be referred to cardiology for an assessment. This is not only for the child, it's also for the parents and other family members who could be affected. If you'd like to get involved with the HCM Act, please contact us through the website. You can go to our UJoin site, which in one click, it's 3 clicks to save a life. Our website, UJoin and send, and you can send a letter to your elected officials asking them to support the HCM Act. Short, sweet, and to the point, making it easy. So stay tuned for more on that. I'm not going to go over all of this, except to say, back in 2020, the HCMA held a patient-focused drug development meeting with the FDA. And I truly believe, with every fiber of my being, that the comments from the patient community and the physician community helped us arrive at a point where when Camzyos came to market, mavacamten, the REMS program met the needs of the patient community, not just what industry wanted it to do, but the patient said, bring it to market and let us have a chance. And now we're seeing more and more patients countrywide being dosed on mavacamten, and many of them are feeling a lot better. And there's been some pretty exciting things happening for some people. I don't think without the voice of the patient that those REMS would have been so willing to allow people the opportunity to try without more data. But we're collecting data as the REMS process proceeds, and over time, hopefully those REMS will come down a little bit and it won't be as cumbersome to get somebody loaded and started on Camzyos. But I think safety is key, and we want to do this very carefully. So thank you for all your voices there. We may be doing another partnered patient-focused drug development meeting, specifically on the topic of genetic therapies for cardiovascular disease. So stay tuned for more on that. So how do we develop and maintain a support system for families? We have our live discussion groups. Many of our centers of excellence have individual support groups that they run. Our social media network is vast. Our private group now has over 9,000 members. Private means it doesn't show up on your Facebook feed, people, so you can join there and have a conversation and not worry about somebody knowing your medical status. So there's an opportunity for you. Now we have nation-specific groups. We have all of our office services as well. And starting this year, we collected money under what we call the Mallory Fund to help provide travel grants to patients and families seeking HCMA recognized Center of Excellence care or transplant care. And we've issued our first grant. If you need travel money to get to a program, we'll give over $600, up to $600 a year per person to get to a center. If you need a hotel room, a plane ticket, train ticket, gas money, money for food on the road, please apply. We have the funds there, they're available, and we want to give those to people who really need them. There are some economic requirements, but you'll fill out a form and you can get some cash to make sure that you get the care that you need. So these are what our Facebook communities look like. When you get to the page, you'll know. You notice on the bottom here, these are our HCMA international partners, and I'll talk a little bit more about that in a moment. But if you want to speak about HCM in Swedish, we can help you. If you would like to speak in Dutch, we can help you. We hope to break out some additional rooms, and I'm hoping for a Spanish language group very, very soon, so you can speak in the language in which you're most comfortable. So we are working to build out more centers of excellence. I'm very happy to say that in the 2020 guidelines, HCMA recognized Center of Excellence modeling was used as the descriptor for both comprehensive and primary care centers for HCM. And we know that it works. So again, we can help you get there if it's a little far away. We know they're not in every community. So please don't be shy about using those opportunities to get in touch with us and to get to a center. As of right now, I'm sorry, this is September and it's November. We have 46 HCMA recognized centers of excellence in the country, with more coming down the pike. We've got a lot to review. So if there's not one in your neighborhood, stay tuned. It might be coming soon. And if you're a physician watching this who are interested in getting involved, please contact us and speak with Stacy Titus. Okay, so I will take a couple minutes on this slide. You're going to start getting some new communications from the HCMA very, very soon. Over 27 years, I've been collecting information as I talk to all of our big-hearted friends, just so when you call back, I knew what to help you with and we didn't have to start from scratch. Well, we're going to take all of that data that's been collected and we're going to put it into a patient journey registry. We're going to challenge some of the current, what we call endpoints for clinical trials. And in fact, I had a really great talk with John Spurtis this week that we're going to be reevaluating KCCQ to make it a little bit more specific to HCM. For those of you who don't know what KCCQ is, it's a living with heart failure questionnaire that the FDA recognizes as a good endpoint. It doesn't exactly work perfectly for us. So we're going to be working with industry and with academic partners on better ways to identify good endpoints for clinical trials in HCM. And the patient voice is going to be very important. So as we build out this registry, you'll be consented in, you can choose to participate in surveys, and we can use that data to help improve our understanding of what is really important to patients and what endpoints we should be looking at. I'm not going to talk more on that one. I will say on this slide, nothing happens in a silo. We are partners here. We all come from unique perspectives. We have industry partners. We have other patient advocacy partners. We are a member of the Global Heart Hub, and we sit both on the Cardiomyopathy and Heart Failure Councils. And Hari and I are both board members in the HCM Society. So nothing happens in a silo. We all have to work together. And as you have seen in the past 2 years, the HCM world has changed. Part of why we have changed is because we are banding together. We are walking in lockstep with each other, although down slightly separate pathways, all towards the same end goal. So as partners, we can go so much further, so much faster. So we are looking forward next year to doing some partnered programs with PCNA, Women Heart, the Arrhythmia Alliance, as well as our industry partners providing support for those projects. So stay tuned. There's a lot of big stuff coming, people. So I mentioned earlier that we're looking to develop out international programs. The first bullet here is the most important. We are seeking to develop and maintain a network of support for people with hypertrophic cardiomyopathy and promote education. Oops, sorry, this is backwards. It's the bottom bullet. That's the most important one. We want to identify and engage passionate patients, clinicians, professionals, societies, government agencies, and industry partners to improve awareness, diagnosis, and management of HCM worldwide. And our first program to this end was launched in September. I went to Sweden to be there for the launch. And it's 2 passionate patients who started the ball rolling. Now they have a committee of 6. They have medical professionals partnering with them. And we now have the HCM Swedish Society as part of our international outreach. 1 country down, about 159 or so to go. I'm not going to run out of work anytime soon. Nothing happens because one person does something. It's a team. And I am incredibly proud of our HCMA team, not only Julie and Stacy who are here tonight, but Elena, Ross, Linda, Olivia, Sabrina, Carolyn, Julie, Cody, Gwen, Nikki, and Emily and Amanda, our other interns. We've grown exponentially over the past few years. We've done so under the supervision and management of our board, and we have had over 100 volunteers provide services this year to the HCMA. And we have about 340 more waiting for assignments, and we're working on those for you now. So if you haven't heard from us, stay tuned, you will. I want to thank the team at Westchester Med and all of the participants this evening for being here. And of course, I need to always thank our sponsors, our donors, our partners, and Brandy, because without Brandy, I wouldn't be here talking to you tonight. So I'm going to leave it there. For those of you who don't know, Brandy was my heart donor. And I'm going to hand it back to Hari, who's going to start us learning all things HCM from the perspective of Westchester.
Thank you so much, Lisa. It's great to hear what you guys have been doing. We've been working together for a long time, so I haven't actually seen that presentation in a little while because of COVID, I guess. So it's good to see all the things that you're doing and really reaching out. So I'm going to hand this over to Dr. Panza, who will take us through the first talk about the evolution and evaluation of the HCM patient, including how we diagnose and the meaning of obstruction. So Dr. Panza, if you'd like to share your screen.
Yes, let me. I have a double screen, so I want to make sure that I share the correct one.
We see your screen. There you go.
You see the full one?
Correct.
Okay, wonderful. Well, again, I want to echo Harry's words and thank Lisa for allowing us to participate and to showcase our program. I was at the NIH when Lisa was a patient there and her sister, and that was more than 35 years ago. So what I would do is talk for no more than 10 minutes and divide it into these 2 words that have similar spelling, but obviously mean different things. They're about the evolution and the evaluation of hypertrophic cardiomyopathy, and I would spend 5 minutes on each. So this paper here is the one that everybody recognizes as the one that I would say started the ball rolling in terms of the diagnosis of hypertrophic cardiomyopathy. It is now a famous paper by a British pathologist, Dr. Thierry, who described perhaps the most spectacular presentations in 8 cases of patients that had a very thick heart, and to the point that he interpreted that this could be a tumor, and he called it, as you see there highlighted, a muscular hamartoma of the heart. The interesting thing about this paper, and of course I don't have the time to go through it in detail, is that if we go with a magnifying glass through it, a lot of the current features of the disease were contained in his description of just 8 patients, including, for example, the fact that this was a genetic based disease through the description of family members that were part of these 8 cases. Now, interestingly, at the same time, in the late 50s, Jim Brangwell, who was the chief of cardiology at the NIH in Bethesda, and Glenn Morrow, who was the chief of cardiac surgery, were actually discovering the same thing. And the story goes that Dr. Brangwell had evaluated a patient with seemingly aortic stenosis that went to the operating room. And he was in his office when Dr. Morrow called him angrily to come to the operating room to show him that there was no pathology in the aortic valve in the patient that Dr. Brangwell had cathed. And Dr. Brangwell put a Mallory catheter and actually demonstrated that there was a gradient between the left ventricle and the aorta, and that there was indeed obstruction. And actually, as told by Dr. Brangwell, they were lucky that they had a second patient coming right away, so that they put that first enigma patient together with the second patient to then describe what is here only 1 year after the paper that I showed before from Thierry, the case of 3 patients that had a gradient between the left ventricle and the aorta, but they had no problem in the aortic valve itself, and that they called functional aortic stenosis. And it was not until about 5 years later, when they were able to collect a total of 64 patients, that the NIH published this paper, which was really the first systematic description of what we now call hypertrophic cardiomyopathy. Very interestingly, and actually I would say very importantly for our current understanding, the focus of the discovery was on the presence of obstruction. Like I said, the very first patient at the NIH was someone thought to have aortic stenosis, so had obstruction. And therefore they had to come up with a different name. Initially it was functional aortic stenosis, but by the time that they had collected more than 60 patients, then they describe it as IHSS. Actually, it's an acronym that is still used by some, which means idiopathic hypertrophic subaortic stenosis, to describe this condition that they didn't know what it was, but there was hypertrophy, and that there was stenosis, there was a gradient, and it was not at the level of the aortic valve, but it was below it, hence the name of subaortic. Dr. Morrow went on to become the father of septal myectomy, the surgery that still is done with significant success, as we will see later during this webinar. The surgery was modified significantly, but he developed his own blade or sculpt to go through the aorta and resect part of the muscle and the basal anterior septum to relieve the obstruction. And this is a picture of Dr. Morrow in 1963. Very interestingly, Dr. Morrow himself had hypertrophic cardiomyopathy, and which is kind of like a sad story. And actually, he passed from complications of hypertrophic cardiomyopathy, a story that actually has been published in the medical literature. Importantly, the first director of the Echo Lab at the NIH was Dr. Walter Henry, who at the time, and working with just M-mode, and these wiggly lines are M-mode echocardiography, basically realized that not all these patients had obstruction, and that the hallmark of the disease was not actually obstruction, but was the presence of a thick septum. So part of the wall that divides the right from the left ventricle was thick. And then they came up with another name, so that not all patients had obstruction, so it couldn't be called IHSS anymore, or at least not to represent all the patients. And they came with the acronym of ASH, for asymmetric septal hypertrophy. Well, over the years, there were so many names that are listed here that has been applied to this condition, only to the confusion of many. And I highlighted in red and green the one that should be used, which is hypertrophic cardiomyopathy, which is the word that we all know, or the words that we all know. And the one that I don't like, which is hypertrophic obstructive cardiomyopathy, and people refer to as HCMA. And I don't like it because it is confusing in the sense that someone may say, well, Mr. So-and-so doesn't have HCMA. Well, may not have obstruction, but does the patient have hypertrophic cardiomyopathy? So, so I think that the term HCM still, I would say, is the one in use by a lot of cardiologists. Should really be phased out, and we just focused on hypertrophic cardiomyopathy as the name of this condition. What happened in the now 60 years, or actually 60 plus years, since its discovery and since its description, is that there was an evolution of hypertrophic cardiomyopathy. Obviously, it's not that the disease has evolved, but our understanding of the disease has evolved. And this is a very nice picture depicting what were the imaging methods that were first used. So HCM was described first when there was no echocardiography. That's picture A, showing a heart with a distal cavity right there in D. I hope you can see my arrow. So this is a left ventricular coronary angiogram that can be done only invasively. Then M-mode echo, and I already referred to that. Then in the 1980s was 2D echo, which still is the most commonly used and appropriately so method of imaging in hypertrophic cardiomyopathy. And it was not until the 21st century that we had the ability to do more accurate and reproducible imaging with cardiac magnetic resonance imaging, and actually, as shown here in panel F, the discovery and description of something that actually had been reported by Dr. Roberts in pathology specimens, the presence of fibrosis in some areas of the heart. The importance of this evolution is that it's changed the way that we think about hypertrophic cardiomyopathy. So first, it was a disease in people who had died, who had a significant thickening of the muscle, and then it has evolved to realizing that in most patients, it's actually a benign condition, and in most patients, actually there is no obstruction, at least at rest. So because it is a very heterogeneous condition, then there's really a puzzle when someone is diagnosed with hypertrophic cardiomyopathy, and all the questions that you see here are probably not do not encompass all the questions that we try to address, but they're perhaps the most significant ones. What is the risk of sudden death? Should we do family screening? If it is a young person who is an athlete, is this hypertrophic cardiomyopathy or is it athlete's heart? What non-invasive evaluation should we do beyond the echo? Should a patient have an ICD? What is the psychological impact on the patient and actually his or her family members? Is it obstructive or non-obstructive form of the disease? Should we do genetic testing? Should everybody or should some patients have an EP study? And then if there is obstruction, should a patient have alcohol septal ablation or myectomy? And those questions will be answered. As I conclude this, I do want to try to simplify all this, and which is what we do here at Westchester. And this slide shows what is our systematic approach to the patient. And there in the red box, you have what we do as the initial and serial diagnostic evaluation, a careful history of physical exam, EKG, echo, cardiac MR, ambulatory ECG monitoring, exercise test, particularly for patients with obstruction, and then genetic counseling, which is even more important than genetic testing. And we do that with 4 clinical foci that are there in green. One is the risk stratification for sudden death. The other one is the presence or absence of obstruction. The other one is the important question, sometimes underrated, of the presence of atrial fibrillation, and of course the issue of family screening. And then in blue, say, okay, what are the potential interventions that each of those clinical foci will or may lead to? The placement of an ICD, drugs or septal reduction therapy for patients with obstruction, anticoagulation and or catheter ablation for patients with fibrillation, and the obviously identification of affected relatives following family screening. And once we identify affected relatives, then they undergo the same evaluation there. An important thing to understand, particularly for patients, is that there is no feature of hypertrophic cardiomyopathy that is common to all patients with the disease. So think about, let's say, obstruction. Not everybody has obstruction. Think about abnormalities on the EKG. Not everybody has it. So there is really no universal treatment approach, and the treatment must be tailored to each individual patient. So in summary, coming to my 10 minutes, HCM is an extremely heterogeneous, mostly benign condition. The patient evaluation requires a thorough and systematic diagnostic approach. The optimal treatment requires specialized centers. Because of the heterogeneity, it is important to have all the diagnostic and treatment capabilities in one center. And importantly, as we will see as part of this webinar, there are new treatments and new prevention modalities that offer promise for the future. So again, thank you. I'm going to stop here and I'm going to stop sharing and take any questions.
Julio, that was wonderful. I'm a history geek when it comes to hypertrophic cardiomyopathy, so much so that I have just mounted the first letter diagnosing the first patient. It was written by Brunwald about Claude Brady. Claude Brady gave me the letter. It now is framed on the wall of the HCMA, and every member of our board will put their fingerprint on the back of the mounting. While Claude and Eugene's fingerprints are on the actual paper, our board members' fingerprints are on HCM too.
Send me a copy.
I can send you a copy of the letter, and you can come down to our office and see the real one hanging on the wall.
Yeah.
But just to add to a little bit of confusion on that nomenclature thing with all the words created, to describe HCM, we now have the pharmaceutical industry to thank for OHCM and NHCM as common terminology we're all going to have to get used to. So just when we thought we had topped it out at 75 names, let's just throw a couple of other new acronyms in the mix just to confuse everybody a little bit more. Here we go. We have a question here. Let me see what it is. Would you suggest when a family member was told that they had it and know her echo shows that she doesn't have it, but is symptomatic? So Esther, I'm going to reword that a little bit for you to ask for some clarification. What comes first, the gene mutation or the hypertrophy? And can you have HCM with only a little h?
Yeah, so that is a great question, and there is a condition that has been termed genotype positive, phenotype negative. As I didn't expand on the genetic testing, but certainly there are at least 8 very clearly identified mutations and 3 others that are very likely, and then many others with less likelihood of linkage to hypertrophic cardiomyopathy. So through this, so if you know that a patient with very well established diagnosis has a particular mutation, then that allows you with a relatively simple blood test, then see whether a relative is affected by genetically. And then obviously that should lead, if not done before, a screening from a phenotype point of view, obviously EKG and echo being the first 2 tests. That can lead to what you described, the presence of a mutation in the genetic testing, but no evidence of hypertrophy. I think that it's important to do a magnetic resonance imaging because sometimes the echo alone, as it is an operator-dependent technique, may fail to identify areas that are in unusual locations. One of the aspects of the heterogeneity of the disease is that the hypertrophy is not always in the same place. And it can be places like, for example, the papillary muscle. So I do think that to say that someone is phenotypically negative CMR is important, particularly if the ultrasound window is not all that great. So
I'll ask one follow-up for her. She clarified by saying this individual won't get genetic testing, but has symptoms, but believes that they're not showing signs of HCM. Can you speak for just a moment on the variability of community-based echocardiography?
Yes, which was a little, I was alluding to that a little bit. So, so because the hypertrophy, we say asymmetric. Asymmetric was referred to the fact that it was the septum and not the free wall. The reality is that it could be anywhere, and it could be more than asymmetric, probably a better word is localized. And the localization of the hypertrophy is very variable. So, obviously, I don't want to be derogatory to anybody doing echoes out there, but if you don't have experience in evaluating patients with hypertrophic cardiomyopathy, and arguably if you're out there in the community, you may not have that experience, then you may miss cases of hypertrophic cardiomyopathy that are not so overt from a morphologic point of view. So to your point, I think it is important that if you're going to rule out the disease, particularly someone who doesn't want to get genetic testing and is symptomatic, then I think that the imaging should be done in a specialized center.
If I can add on that, the other thing is that sometimes as we've evolved, we realize that sometimes a referring may call it HCM, but then with MRI, it doesn't meet the criteria. Or we find a mimicker like amyloidosis or hemochromatosis or something else. And so it's not necessarily always that there's a poor ability to discriminate this induced echo on the outside, but rather a deeper dive into these patients may arrive at the true diagnosis in these patients. So I think that's another aspect too that might answer some of that question.
I agree there completely. We're not dissing all the echo techs out there, but if they don't have a protocol that is specific to HCM, it is easy to miss particular views in areas of hypertrophy. I spent my afternoon with Dr. Bill Roberts down here at Baylor doing sectioning of some HCM hearts, most of which were post-transplant, two were not. They were death cases. But when you look at the anatomy of HCM in front of you, I've now done this with 8 different HCM hearts, no two look alike. The pattern of hypertrophy is highly variable. The positioning of the papillary muscles are a little bit different, a little bit wonky. We're all trying to get to better imaging, but I think the best chance that somebody has to get a good answer is to go to a high volume. Even if it can't be an HCMA recognized center of excellence, go to an academic medical center to get your imaging done if your family members are being screened. Don't go to the doc down the street. The likelihood of paying for something that's not going to give you an answer that's useful is quite high. If you go to an academic medical center, you have a much higher likelihood of getting a higher quality image. So I will step off my soapbox now. Hari, back to you.
Yeah. I want to make one comment, and I think our team is going to talk about that, which is oftentimes patients get an echo elsewhere or they're about to get it, and we say, wait, don't wait until you come to ours, because sometimes from an insurance standpoint, it gets challenging to do an echo, then another one a week later or 2 weeks later. And as you mentioned, we have a distinct HCM protocol here with Definity, with multiple views in different locations to make sure we don't miss aneurysms, lateral wall, and we do a really stepwise approach to the obstruction. So it is very detailed, and patients who are listening should know that it takes us about an hour to do each of these echoes fully. And because of that, we, I think, arrive at a stronger diagnosis, and sometimes can get more of the information before even the MRI, which is helpful. So thank you. We're going to get going. So that's great. I'm going to do the next talk. So I'll share my screen again. Okay. Great. So this will be evaluating and managing the obstructive patient. And so you heard from Dr. Panza about obstruction ends up being present in about 70% of patients, either at rest or on what we call provocation, when you're doing a Valsalva, holding your breath, or under exertion, climbing stairs or running. That's what we call latent obstruction, meaning the obstruction comes out or is evoked by exercise or some other kind of manipulation or provocation to the patient. So most patients end up having obstruction. It becomes very important to know whether they have that. And this slide tells you why. Essentially, you have a patient with HCM, as many of you are in the audience, that results in some degree of dysfunction, what we call diastolic dysfunction, or reduced compliance or stiffness of the heart that doesn't allow it to open fully. So there's some effect on the heart function that is usually related as fatigue to the patient, but they may not know it, because as they get older, most people get fatigued for lots of reasons, and they may not realize that they're slowing down or not able to do as much. In some patients, as I mentioned, about 70%, they get this obstructive physiology from ASH, as Dr. Panza just mentioned, and what's called systolic anterior motion of the mitral valve. This causes obstruction. And really, once you get obstruction, the reason why we end up focusing on obstruction is twofold. One is because obstruction causes a lot of symptoms. It makes the valve leaky. It can cause atrial fibrillation, as we'll hear about soon. It may cause the lung pressures to go up over time. Certainly, it impacts what we call the cardiac output, or the amount of blood flow the heart can pump per minute. And it can result in dizziness or even passing out as blood flow doesn't get out at times and resulting in a drop in blood pressure acutely. Over time, this obstruction also causes the heart to get thicker because the heart tries to get stronger and stronger as a result to push blood out of the outflow tract. And so it causes a vicious cycle where patients get worse and worse and worse. And that's why obstruction is very important. The other reason it's important is because most of our treatments for hypertrophic cardiomyopathy center around relieving obstruction. So if we make that diagnosis and it's causing a lot of your symptoms, we actually have certain treatments that can benefit that, as we'll talk about here. So what are our therapeutic goals for patients with HCM? Well, we really try to individualize the therapy. And Dr. Panza mentioned that each patient is a puzzle. And I do think that that is a very unique aspect of our program. And we hear patients from other programs, and not to disparage again, but rather we try to take a very individualized approach. What are the goals of the patient? And what is the physiology of this particular patient in front of me? And how can I manipulate that physiology for this individual patient to make this individual patient better? And I do think that that goes a long way, because some people will just put them into buckets. You're non-obstructive or obstructive, and for obstructive, we do A, B, and C for all patients. And non-obstructive, we do A, B, and C for all patients. And I'm not sure patients like that, nor do you get to the most effective therapy for the individual patient if you do it that way. And so we take a different approach. We want to improve their symptoms short-term. We want to long-term try to impact things like fibrosis or the scar we just talked about, try to defervesce or make the heart less thick, and certainly want to try to see if we can improve survival. We did hear that for most patients, it's a benign course, but the truth is once you have symptoms and obstruction, it's not benign. These patients tend to have a higher risk of arrhythmias, atrial fibrillation, heart failure, and they can oftentimes struggle. So our goal is to try to improve that struggle, get them back to a normal state where they can enjoy their lives, and let us worry about overall prognosis and survival for them, which would be hopefully improved. The mainstay of treatment initially, especially for the obstructive patient, are beta blockers. So many of you may be on metoprolol or atenolol. There are other non-selective beta blockers as well, such as carvedilol and bisoprolol that we can use. Sometimes we'll use verapamil or diltiazem as a second agent. These are mostly for patients who have continued high blood pressure that need something on top. Or there are patients who have wheezing, and we don't want to exacerbate the wheezing with beta blockers. So we move to a different agent that doesn't have that. And then finally, at our institution, we probably have a good 20% to 25, 30% of our obstructive patients on disopyramide, which is an antiarrhythmic medication, but really works well at reducing obstruction from a medication standpoint. Now, the problem with medications, and many patients talk to us about this, is that twice daily dosing can be challenging. Many people will miss the second dose, even if you're the most compliant, trying to be the most compliant patient ever or person ever. It's hard to take something every day, let alone 2 times or 3 times a day. Norpace or disopyramide is 3 times a day. Beta blockers and calcium blockers oftentimes are twice a day, and they cause all these side effects that when you treat one thing, you're also poisoning the system with something else. And so we try to balance that out so patients do well on balance, and everybody has different side effects and different symptoms. But you can get bronchospasm, wheezing, heart rate can be low. Certainly people complain of being more tired. There can be impotence, and there could be other EKG abnormalities, some of these drugs, as well as constipation, glaucoma, urinary retention with disopyramide. So they're not benign, but they do certainly help. And in general, the benefits outweigh the risks, but these are things that make medication a problem for many patients. The third thing about medications is they don't really change the actual disease or heart function. So they kind of manipulate the heart so it behaves better, but the heart's not actually getting better. If you're not on the medication and you miss a couple of doses, or you travel and you don't get your prescription and you don't have your medications, they will feel worse. And they mention this, and it makes them really kind of dependent on the medication to make sure that the heart is able to allow them to function normally. And this last point is the same thing, which is that it only works while taking the medications. And that's a problem if all of a sudden you can't take your pills after a surgery, and all of a sudden now, right when you're trying to recuperate from surgery, your heart is in worse shape, and that becomes very challenging for both the patient and also the medical facility and the physicians taking care of those patients. So for all those reasons, different institutions have moved more towards what we call septal reduction therapies, which is the 2 ways of invasively improving obstruction in patients. And I would say at Westchester Medical Center, we're more on the left, which is that we do use a lot of medications for these patients, and we'll talk a little bit in one slide about the new medications that have just been approved, or one of them, and with another one right behind it. But we probably do move to septal reduction therapy a little bit earlier for the reasons I mentioned. Medications work, but you'll know pretty quickly if they're working well enough. And if they're not, and the patient really desires more quality of life and functional status, we will move to a way to more definitively treat that obstruction and hopefully improve the heart function. And those are the two therapies you see on the left here: septal reduction therapy, alcohol ablation, and myectomy. So this is a busy slide, but the bottom line here is that for both myectomy and alcohol ablation, it's the same indications overall. The patient should be symptomatic. They should have at least what we call class 2 symptoms, so shortness of breath, doing activities that they really should be able to do for their age and their body habitus, or class 3, which is or class 4, where they're short of breath or having dizziness or lightheadedness, even climbing stairs. They have to have a thickness of the heart at least 1.5 centimeters. They have to have significant obstruction, meaning that the gradient has to be more than 50. And we didn't talk too much about gradient, but that means the difference in pressure inside and outside the heart, which should be 0. But in patients with hypertrophic cardiomyopathy with obstruction, it goes to over 30. And if you're over 50, that usually means that there's a lot of obstruction getting in the way of blood flow that might be helped with a alcohol ablation or myectomy. Okay, so just 2 slides on alcohol ablation and myectomy. This is just to diagrammatically look at it for you patients in the audience. Ablation was a way of using catheters that we usually use for angioplasty and stenting and fixing heart attacks, but rather we use the wires and balloons to get into the area of the heart that is actually bulging and too thick. In most of the patients, they don't have this anatomy. They have a relatively thinner heart, except for the right here at the basal septum. And so those patients who have very focal hypertrophy, usually older patients, get an alcohol ablation oftentimes, and that can shrink the heart right here where the blood has to leave the heart. The benefits now is that, it's been around now for over 25 years. It's minimally invasive, so our patients are awake and alert. They get minimal sedation, but they're awake. It does therefore avoid general anesthesia and intubation and sternal incision and healing that normally comes from open heart surgery. And ideally, if you choose the right patients, you can maintain the clinical benefit of surgery without when done in appropriate patients. And that is key, and we'll talk about that. And finally, not that it's important for the patient necessarily, but length of stay is, but reduced cost has also been seen with this procedure. Dr. Malekan will talk about myectomy, which I think we've done a really terrific job of here at Westchester Medical Center, and an extremely important procedure. This has not been performed for over 50 to 60 years. It's certainly fine-tuned at centers of excellence. And there's only, as you saw, a few, 40 or so. Not all of them are doing myectomy. Lisa can talk about that. But the ones that are doing high volume, which we would say is more than 15, 20 a year, at least 1 or 2 a month, they have significant expertise to do this properly. So it's a one and done procedure. Typically it's 2 cuts, echo guided, anesthesia guided as well. Excellent symptom improvement and long-term survival if done appropriately with low complications. Of course, it's open heart surgery, but these patients do quite well. They typically are younger patients who can tolerate that. But of course, in older patients, that might be a problem. So we published this a few years ago, looking at the main centers of excellence for alcohol ablation. And at the time, and I still think today, we're probably the busiest in the country. These are the other firms that are doing alcohol ablation. I do need to update this list, but just for people to see, where to look for this procedure. This is not all the hospitals that have myectomy. That list is probably far fewer. For those of you not used to seeing hemodynamics, this is what we see in the cath lab. We tend to see 2 tracings. We see a left ventricular tracing. This is the larger one. So the blood pressure, to orient patients, this is the blood pressure, this top number, the blood pressure in the ventricle. And then this is the blood pressure in the aorta. This is the blood pressure you take if you did it in your arm. And this is what we see in hypertrophic cardiomyopathy, which is that a lot of the pressure is bottled up. So the pressure in the heart is much, much higher than the pressure outside the heart. The other key point in hypertrophic cardiomyopathy is it's variable. And this is why you may have a good day or a bad day, or if you're dehydrated or after a meal, you may feel worse, because the gradient, this obstruction, gets worse and better at different times, depending on all of those features. If you're dehydrated, if you're excited, if you are in a gap between when your first dose of medication and your second dose of medication. And this is why patients will oftentimes say that some days I'm better, some days I'm worse. I don't understand. But that's because the disease is variable, what we call dynamic. We also see that after an extra beat, the gradient goes up tremendously. And patients will oftentimes feel this even on the table, as all of a sudden they can't get the blood out. They'll feel like a big, strong heartbeat. And patients with HCM oftentimes mention these big, strong heartbeats, which are really just extra beats, but are felt so palpable by patients because the heart is so thick. And also when that happens, a lot of the blood goes backwards. And so they feel it in their lungs. They may start coughing. So if you notice any of these things is something that you find are in your symptoms, These are all signs of obstructive cardiomyopathy, hypertrophic cardiomyopathy. After alcohol ablation or after myectomy, we see the gradient essentially disappears in these patients. And this is an echo from a patient about 10 years out from alcohol ablation. And for those of you used to seeing echoes, this is the same cross-section that we showed the alcohol ablation. The thickness here is now gone, and you can see all the blood can come into the heart and out of the heart because all this area is now improved. There's lots of room for blood to flow. So in essence, alcohol ablation and myectomy break this cycle. They negatively inhibit this cycle. All of a sudden, the obstruction goes down, the symptoms improve, and LVH mean that how thick the heart muscle over time improves as well. So last couple slides, in 2020, the AHA-ACC had a guideline that came out. This is the second guideline in HCM. I was involved in the first one in 2011. There's a second one here. And then Lisa, I think you know, they're in the plans for doing a third guideline. I'm hoping I'll be on that. I did get the initial nod, but I'm waiting for the final confirmation. And that should be out in 2024 as an update with all the things that are happening, including mavacamten. So where they take us through is that you take an HCM patient, you should treat their comorbidities according to guidelines. That means if they're diabetic, if they're obese, if they have other problems, you need to treat all those as well as possible to not compound their HCM problem with other problems. Then you determine if they're obstructive, because that, as I mentioned, is a key component in how you treat these patients. If they are obstructive and they're symptomatic, well, now you start beta blockers. You can consider verapamil or diltiazem. You can move on to disopyramide, or you can move on to septal reduction therapy. And then in septal reduction therapy, you can either go to alcohol ablation or myectomy, depending on a variety of factors. Obviously, if they need surgery for other reasons, let's say they have a tight valve or a very leaky valve that is intrinsically abnormal, these patients need surgery, or they need bypass surgery as well. So oftentimes those patients will shuttle over to myectomy with some other procedures. One of the challenges in the guidelines is that I thought that it really didn't pay enough attention to how we choose these. Now at our institution, we have a heart team meeting with about 10 different individuals, including the surgeons and the clinicians and imagers and all of our NPs and PAs. And we go through all these cases. And the truth is, it's not really so obvious that you can just choose one or the other. The truth is that I would say 90% of patients, it becomes very obvious which one is better for them. And so we almost never tell a patient, you know, you can choose one or the other, and these are the differences between the two procedures. It's not about that. It's more about what is your disease and how would you most likely get 99% success with the least risk. And we choose that procedure for that patient. And this just diagrammatically shows that. This is a publication we wrote a few years ago that looks at all the issues that we talked about in our heart team. So we have an evaluation by a multidisciplinary team, which I actually really enjoy these meetings. Dr. Panza is there, our whole team is there, Dr. Malekan is there. It's actually a really nice time in the morning to talk about patients and quickly really put our heads together and what we need more for each of our patients. But we look at all these different things, and there's so many factors that are involved, including patient preference, but really most of it has to do with what is their risk for complications from each of them, and what is their likelihood of benefit from each of them. And then we take the risk-benefit ratio of each of those and figure out who gets alcohol ablation and who gets septal myectomy. So the last slide here, I think, is on the new medications. So now that we've figured out, you know, who is obstructive, what are the typical medications, what are the septal reduction therapies, all of a sudden we're throwing new drugs at us well, where do we put this in? So here are some questions for the new drugs. I'm not going to get into it too much, but we can in the questions in the Q&A. Is number one, can these new pharmacotherapy medications, which by the way are once a day, can they delay or obviate, eliminate the need for septal reduction therapy? I think that's important to discuss. Number two, will they replace beta blockers and other medications? Those medications have side effects. This one has less, at least so far. Should we replace them? About de novo patients, should they go right onto this and not try the other medications? And then finally, over time, will they produce the same remodeling or improvement in the LVH and the other areas of the heart, such as atrial dimensions and improvement in survival we are seeing with septal reduction therapy? We don't know this, and this may take some time, but it is an exciting time for HCM that we have new aspects in our toolbox. So summary of novel meds and SRT, you know, medications definitely can avoid invasive procedures. Maybe they'll delay SRT. They may target both scar and obstruction. We're seeing some evidence of that. On the flip side, though, there is a concern of getting heart failure from these medications, though we haven't seen that yet. And I think we're being very careful, and the company is being very careful as well to make sure that patients are on low doses to the beginning and really stay at that dose for a few months to make sure that there's no untoward effects before increasing. So we haven't seen any, and to be honest, all of our patients have done really, really beyond expectations. But that being said, we do have to be concerned about it as we roll this out. The mild improvement in NYHA class, maybe it's going to be stronger, but we're still watching. And obviously, we don't have large amount of data on these medications yet. On the flip side, the invasive therapies have done really well in a number of ways, as you can see here. But on the flip side of that is that not every place has myectomy and ablation, and that's not really fair for patients who are not within 5 hours of a CLE. So are there therapies like these medications that might be able to get these patients better without the need for invasive therapies? So I want to thank you very much. And with that, I'm going to stop sharing. And then we can ask a couple questions, or we can move on depending on timing, Lisa.
We'll give them another minute to post their questions. That was an excellent presentation. Thank you, Hari. We've come a long way since the toolbox was sparse with not much to do.
Right.
And, I go back to one of those original articles, well, I won't call it original, but early days articles that patients choose alcohol ablation. And we've learned that your anatomy chooses your options.
Exactly.
And, we went round and round with that one for a long time, trying to get people to understand, but I think finally they're there. And hopefully because they're there, we have a better understanding of who is a good candidate for what. So I don't have any questions popped up yet. So why don't we move on, and we'll hold any other questions until the end of the night.
Perfect. Let's move on. So Dr. Malekan, you're up if you want to share and take us through myectomy.
Sure. Let me see if I could try. Can you guys hear me?
We can hear you and we can see you. Perfect.
Fantastic. Okay. First, I want to thank Lisa and Dr. Naidu, Dr. Panza for the invitation. Being the third in line in presenting makes my life, my job a whole lot easier. I was going to tell you most of the stuff that is already mentioned, so I could just focus on telling you about what we do in the operating room. Just see. So when we meet during the conferences to discuss individual patients, obviously this is a very comprehensive meeting. What we do is we focus on the problem. Obviously, the patients are being selected when we feel that there is a benefit from surgical intervention versus other modalities. And this is very important to remember. What we do in the operating room is one of the things in the whole spectrum of how the patients are being treated. So usually they are seen by the cardiologist. The recommendations are for different medications, and the patients who come to us, most of them, they have obstructive symptoms. And then we define the problem. Here I'm going to talk about the technique of transaortic myectomy, how we actually do it. There are many other factors involved in the operation, whether the hypertrophic cardiomyopathy causes other symptoms. Is there any mitral regurgitation? Is there any obstruction in other areas? And one thing that Dr. Panza mentioned, and is absolutely true, there are no two patients that they're the same. The variability is one of the first things I learned about this disease. And if you consider 1 in 500 people, they have HCM, that puts about at least 500,000 people in the US that they have this disease. So you could imagine what we see when they come into the surgical treatment is really the tip of the iceberg. I'm also going to briefly mention a different variant that usually it's a very small part of the surgical practice, but here, because Dr. Naidu and Panza keep us very busy, we actually tend to see a big proportion. They should be in single digits in terms of the percentage of patients, but I could tell you the complex, very complex cases are up to 20-25% of the patients that we see. Most of the time, again, this is a postmortem heart. When they talk about HCM, they show you a picture like this. You have to keep in mind, these are rare, but we do see patients that they have very severe obstruction. The key point is, if you have obstructive symptoms, it puts you in a different category of patients, not only in the terms of having symptoms, but also in terms of life expectancy. Patients who don't have obstructive symptoms and they have HCM, they have much better prognosis. Now, having said that, The good news is, if you have obstruction and you have surgical myectomy, essentially it puts your survival curve is almost superimposable as that of general population. So the patients who do come to surgical myectomy, they tend to do very well if you keep the complications down. We discussed there is really lots of variations of the disease. Most commonly, and this is what we like to see because it's very straightforward, is when patients what we call basal septal hypertrophy. This disease is localized, relatively easy to do, but you could see all other variations. If you look at the panel in the bottom, you could see this entire heart is hypertrophied. This one, it shows you that the septum is hypertrophied all the way down, and we're going to discuss that. In order to do a debulking of the septum, what we do is we do two approaches. Half of the septum is taken out through the aortic valve approach, and then the other one through what we call a ventriculotomy. We have to open the heart to access the septum from the bottom. Harry showed the similar echocardiogram here. The basal septum, it shows you that as the heart is contracting, instead of what we call the left outflow tract being wide open and allowing the heart to eject, essentially it collapses the LVOT, and then that's what causes the patients to have symptoms. So if you could imagine, we remove this part of the muscle, the outflow tract becomes nice and open. So the way I explain the procedure to the patients, I do emphasize that the patients receive general anesthesia. This is really important for me to communicate to the patients that when you have general anesthesia is very different than what we call going to sleep. When you go to sleep, someone could wake you up. When you have general anesthesia, nobody could wake you up until the gas that you're breathing and the medication is being given are turned off. So this, I think, it's important for patients to understand that when you go to the operating room, you would have no recollection of what goes on. And I think that helps them with the reduction in most patients are very apprehensive. This puts their mind at ease. The techniques of myocardial protection, how we protect the heart when it's stopped, they have changed profoundly over the past 20-25 years. It's extremely uncommon for us to arrest the heart and not be able to put it back on. It just doesn't happen. It's extremely, extremely rare. This is the video that's being shared by Dr. Schaff. Doing a video of myectomy is very difficult because you have to look into the tunnel. So this video has very good quality. It shows you that the aorta has been opened. Obviously, the heart had to be arrested. And this is the surgeon's view. Very interesting. You see where the septum is, there is a white band. And that's this point that the septum is making contact to the opposite side and causing obstruction. We usually do two cuts. One is the first cut that's relatively easy to see. Let me go back up. I'm sorry. Let me just, that's the first cut. Again, relatively easy to see. We use what we call the number 10 blade. It's the blade has about 1 centimeter thickness. And then we do this sewing motion, and then right at the tip where the knife is traveling, right here is actually the aortic valve. So you have to be very accurate within a couple of millimeters. If you go a little bit extra, you could damage the valve. And as the blade here is traveling, what you see is where we're lifting up the muscle with pickup, the mitral valve is right there. Those are the cords. So if you make a mistake, you could damage the mitral valve. So it takes a bit of finesse, but you know what I always say, every open heart, it is a little bit finesse. So you just have to be very careful. Usually I do this with Dr. Spielvogel, so he helps me with the exposure. He shows me the structure so I could relax and do a good job. I'm taking all the muscle we need. We usually take a little bit more than it needs just to give us a little bit of a safety margin. So here it shows you the first cut. Obviously, this patient has a very thick septum. This is a very nice portion. We're going to put it back in just to show you. There you go. And you see the white band, that's where the obstruction was. This is where the septum was hitting the opposite structure. Now for the second cut, and this is just as important as the first cut, you need to have this come to your view. So one of the way it's done, you ask your assistant to press over the heart, and I know where to ask him to press because it's exactly where the anterior descending artery is located. By pushing down, you bring the part that's towards the apex of the heart into your view, and similar to the first one, you do the second cut. This cut, again, is very important. We see patients that they've had myectomy in centers with less experience, and this is the cut that's being missed or haven't been done adequately. Again, you want your blade travel as deep as possible, but not too deep, because if you breach the septum completely, that's a very big complication. That's causing what's called a ventricular septal defect. That's very troublesome. So we haven't had that complication. So as you could imagine, it takes a little bit of accuracy in terms of taking just enough to relieve the obstruction, but not too much to causing problems. Here you see the aortic valve leaflet protruding into the view. Once all the muscle is out, you look for any other portion that you think it needs to come out. Once all the muscle is out, we examine all the structures. Once we're happy, we look at the aortic valve to make sure we didn't cause any problems with the aortic valve. Here we look at the coaptation. Then the aorta is closed, and the patient is weaned off cardiopulmonary bypass. I did one yesterday. The entire time that the heart was arrested was about 30 minutes. That includes giving cardioplegia for 10 minutes, doing the myectomy, and then closure of the aorta. We usually close it in 2 layers. That takes about 15, 20 minutes. So I think the part that I did the actual myectomy was probably about 3 or 4 minutes. So one more time going over the diagram, that's the first cut, second cut, and then occasionally, this is what we also look for, any abnormal connection between the tip of the papillary muscle and the myocardial septum. That's actually relatively common, probably about 10, 15% of the time. If you see abnormal communication, we usually transect those. And this is a echocardiogram of a patient who had a myectomy. You could see here where the muscle is being cut, outflow tract is wide open. For the interest of time, I'm going to move to the next segments where you have either the myocardial septum towards the apex is causing a problem, causing midcavitary obstruction, or in this case, when the entire septum is very thickened. For that, what we do is, in this case, half of the septum is taken out through the aorta, and then from the apex, we take the other septum, creating a cavity. So this is, again, with obviously this is a different patient with the heart arrested. We put this laparotomy packs just to prep up the heart. Usually the heart looks very thick from the amount of muscle that's there. You cannot sometimes squeeze the heart because there's really no cavity. So what we do is we make a ventriculotomy. This is the beginning. The papillary muscles are very close. So as soon as you open and you see any cavity, here the assistant shows me where the papillary muscles are and where the septum is. And you have to be very careful. If you damage the papillary muscles, you might end up having to replace the mitral valve, which is a complications you try to avoid. So then what we do is we take our time, little by little, take off myocardial septum, and then you put your forefinger and your thumb and you measure the thickness of the septum, and you move towards the base of the heart. Now, if you already have done the resection from the aortotomy, you want to see the tunnel that you have created, and you see that both septum that you have resected, they actually meet into a nice area that you have created a nice cavity. here is a very good example of that. And I think two things cause improvement in symptoms. One is you relieve the obstruction and you enlarge the cavity, but also I really believe by debulking some of the muscle, the heart is allowed to relax more. And I think that's a very big attributor to patients feeling better post-operatively. These are the patients that they could be offered transplant. That's a good option for some patients, but you also have to remember patients who have to, when they come to transplants, they have to take immunosuppression. There's in some cases, there's a decrease in life expectancy. So if we could do this significant operation for patients and debulk their heart and buy them some time, and by that I mean 5 years extra time to transplant, 10 years or 15 years, I would think that's a big favor for our patients, and then they could go on to have a transplant if all the other options are exhausted. So once all the muscle is taken out, we actually use a big suture and either a felt or bovine pericardium to close the ventriculotomy. Amazingly, it's uncommon for this portion of the heart that you open to bleed. So the heart comes back beating. These are the cannulas we use to put the patient on heart-lung machines. Once the operation is completed, we remove the cross clamp, the heart gets perfused, the heart starts beating, and all we have to do, make sure there is hemostasis, and then we close the chest. The patients typically do extremely well. That's concludes my talk. The difference between a talk given by a surgeon is we'll show a couple of videos and we're off the hook. And then the medical doctors and cardiologists, they show you 50 slides full of data. And I really have a tough time ever remembering the data. So I had the easier job.
Thank you, Ramin. That's fantastic. Thank you for putting the videos in there as well. I think for patients who are watching, hopefully that was helpful and not too difficult for the non-medical community.
I will tell you that we get very good replies from the patient community when they see surgeries. They like to see it in real time. And I'll share with you that I saw something today that I've never seen before. And in fact, Dr. Bill Roberts had never seen it before. We were sectioning a few hearts that are post-transplant. And the one heart we both looked at and went, what is that? And it was a post-apical myectomy transplanted patient. She's doing very well today. So as you said, sometimes it gives them some time, but I'd never seen the stitching in the apex. And we were both a little confused when we saw it. And I'm like, wait, let me go back to the record. I think she might have had an apical myectomy. So we've seen the aftermath, and that's a lot of stitching down at the apex, but it looked like it had healed quite well, actually. So live and learn, and every day. And Bill Roberts, who's seen everything, he's like, I've never seen one of those before. So he had the opportunity to see one. It was kind of interesting. So we do have a couple of questions. Let's see what we have to say here. Oh, okay. So Esther's saying, thanks. Doing my transplant in 2018. So one of your former patients is chiming in just with a thank you.
Thank you.
We have an alcohol ablation question here. So we'll just offer anybody if they have any questions about myectomy. And to those of you who are watching on Facebook, I'm going to try to do a thing because we have about the same number of people watching on Facebook as we have in the live Zoom room. If you have any questions, I'm going to keep an eye on this for a little bit and see if maybe I can moderate both at the same time. So sometimes Facebook doesn't catch up in live time. So you can ask a question. If I miss it, I'm sorry, but I'll try. So the question is, I had an alcohol septal ablation in 2018. Why does my blood pressure keep dropping? Goes below 140, I get woozy. I can't walk straight, and I get brain fog. Keeping my blood pressure higher, I feel better. So what's the payoff here? Is a higher blood pressure good, bad, indifferent, or does this patient need to come in and be revisited?
Yeah, I mean, that's so doing lots of these and both myectomy and alcohol ablation, that's not a normal symptom. So I would say that's not something that's something we'd want to figure out a little bit more. So after ablation or myectomy, you really shouldn't have any gradient, or it should be controlled at that point. So I could see why if there's some obstruction remaining, their blood pressure may drop, but the whole 140 thing is a little odd. So we'd want to see what the blood pressure really is there obstruction, and then try to figure out why below 140 you're getting some problems. To be honest, it may not always be the heart. Sometimes you may have carotid disease. I don't know how old this patient is, but you may have carotid disease or other disease of the brain. And some of those patients require a higher blood pressure so that they feel better. But the treatment really is not to keep the pressure higher, but really to find out why, when the blood pressure drops, do you have symptoms? And so a doctor should really take a good look at that. So I would recommend, I don't know what that patient is, to come to a center of excellence and try to figure out, A, did the procedure work? What needs to be done for that, if it needs to be repeated or you need additional medications? And B, why is the blood pressure dropping and resulting in symptoms? So I think a good evaluation of that is required. I wouldn't sit tight on that one.
I would agree. Don't have any other questions, so let's move on. And if we have other questions, just post them as we go.
Okay.
And
I think
Facebook
Dr. Jacobson is next. So
getting quiet.
Dr. Jacobson, if you have your presentation, you can go ahead and share for us. Thank you.
Sure. All right, let me get my presentation up. Nope, that's not what I want.
Dr. Jacobson looks very fancy tonight. He's got his nice backdrop and his suit and tie.
It does.
Cleans up well.
Thanks. All right. I am going to talk about just a little bit about managing some specific arrhythmias. I'm not going to talk about everything because there's just not time for that. So again, I'd like to thank Lisa and the HCMA for giving us this opportunity to showcase our program, and Hari, obviously, I'd like to thank for leading our program. I've known Hari for at least a quarter of a century, I guess, by now. So just really basic heart rhythm stuff, I think, so everybody can understand arrhythmias and abnormal heart rhythms. I think it's beneficial to just go over quickly the heart's normal electrical system. The heart is an electrical organ. It's the electrical signal that tells the heart to contract, to beat. So the heart has its own natural pacemaker called the sinus node or the sinoatrial node. And when the sinus node is generating the rhythm, we call that sinus rhythm or normal sinus rhythm. The sinus node is located at the top of the right upper chamber, the right atrium. Now that signal spreads throughout both atria, the right and left atria, and then needs to get into the ventricles. And remember, the ventricles are the main pumps for the system, specifically the left ventricle, which ejects blood out of the heart to the aorta, to all the arteries. The right ventricle sends blood to the lungs to pick up oxygen. So there's a little bit of a gatekeeper here at the bottom of the right atrium called the AV node or atrioventricular node. It slows the signal down a little bit to allow for a pause between when the upper chambers contract and the ventricles contract, to allow for the atrium to give a little extra kick of blood to help the ventricles start off their squeeze. And that AV node then divides into branches of wiring, essentially, that activate the right ventricle through the right bundle branch and the left ventricle, which you can't see here, through the left bundle branch. So let's talk about tachyarrhythmias or abnormal fast rhythms. And there are a few specific rhythms that I think we need to focus on in patients with hypertrophic cardiomyopathy. A big one that has been mentioned a few times this evening is atrial fibrillation. Fibrillation refers to an irregular or chaotic rhythm where there's really no organization of the rhythm. It is the most common arrhythmia that we see in patients with and without hypertrophic cardiomyopathy. And you can have fibrillation in the atria or the ventricles, but atrial fibrillation specifically is a rhythm that we see very commonly. It generally starts in the left atrium, but obviously both atria are involved. And the atria are beating many hundreds of times per minute. While the ventricles are somewhat protected by that AV node, which slows the signal down, they can still be very rapid and very irregular. And this can cause a number of symptoms. And the number of symptoms can include shortness of breath, chest discomfort, lightheadedness, even passing out for some people. And the reason for this is because you lose that atrial kick. And in hypertrophic cardiomyopathy, with stiff hearts that don't fill as easily, that loss of atrial kick can be really significant. Again, that and the rapid irregular beat can lead to poor filling of the left ventricle. And the other issue is blood clot formation, because the upper chambers are really just kind of quivering instead of beating. Blood stagnates and blood clots can form. And those blood clots can actually lead to stroke. And in patients with hypertrophic cardiomyopathy, stroke is much more of a problem in patients with atrial fibrillation and HCM than in patients with atrial fibrillation without HCM. Stroke risk is about 5 times higher in the HCM AFib population. So it's really important for anybody with HCM and atrial fibrillation to be on blood thinners to help prevent stroke. We also control the rate of the ventricles with medications like beta blockers and calcium channel blockers to further slow conduction through that AV node to prevent those fast ventricular rates. But often we do need to employ what we call rhythm control. And rhythm control is the restoration and maintenance of normal sinus rhythm. Many times the first approach is something called cardioversion or direct current cardioversion, where a controlled shock is delivered to the chest under sedation to essentially reboot the electrical system. It does a great job of restoring a normal rhythm. However, it does not prevent atrial fibrillation from reoccurring in the future. So many times we'll use strong medications called antiarrhythmics, which act directly on the heart's electrical properties to maintain a normal rhythm. However, these are not, effective in everybody, maybe work about half the time. So we also have a more effective approach called catheter ablation. And what we do with catheter ablation is we go into the heart with special catheters through the veins in the groin. So a number of catheters can go into the heart, and we're basically ablating tissue responsible for atrial fibrillation. What do we mean by ablate? Well, we're applying an energy source that essentially devitalizes that tissue, and eventually it becomes scar. There's 2 approaches that we use at Westchester Medical Center. One is radiofrequency, or essentially cautery, causes an electrical burn. The other is cryothermal, or freezing, via a type of catheter called a cryoballoon, that the balloon just fits inside where these pulmonary veins, the veins bring blood back from the lungs to the heart, to the left upper chamber, the left atrium. And this balloon just kind of fits inside that opening and freezes it. The other modality we use is radiofrequency, or burning, where we go point by point around the pulmonary vein openings to create those lesions. There are a few other ablation modalities out there in varying stages of development, but these are the main 2 that we use. And actually, we do prefer radiofrequency for patients with hypertrophic cardiomyopathy because it gives us more controllability and the ability to go after other areas that might be behind atrial fibrillation as well. While the pulmonary veins are the primary source, some people have additional areas that need to be ablated. Ablation can be applied to any tachyarrhythmia. Atrial flutter is another rhythm sometimes that we see that goes along with atrial fibrillation. Where atrial fibrillation I liken to a bunch of little tornadoes spinning around the atria. Atrial flutter is just one big hurricane, and patients can go back and forth between the 2 rhythms. There are other supraventricular tachycardias, or tachycardias originating from the upper chambers, that can also be targeted. We use special computer technology to track our catheters and create an image of the left atrium, and also tells us areas of scar based on the voltage signal. So heart being an electrical organ generates voltage, normal voltage being colored purple, abnormal voltage and very low voltage being red. So sometimes we have to target these areas as well. We also have special echo probes within the heart that allow us to directly visualize the heart itself and the different structures. And we can identify the structures of the heart, like the different pulmonary veins, the outpouching in the left atrium called the appendage, and even other areas near the heart that we need to be aware of, like the esophagus. So let's go south and start talking about ventricular arrhythmias, specifically ventricular tachycardia and ventricular fibrillation. Hypertrophic cardiomyopathy patients may be at risk for sudden death due to these arrhythmias. Most commonly in HCM populations, the cause would be ventricular fibrillation. And just like in the atria, fibrillation is irregular and chaotic in the ventricles. Patients can also have a more organized rhythm, somewhat akin to atrial flutter, called ventricular tachycardia, which is again due to a circuit within the heart. And generally, this is more regularized and fast, but can still be very dangerous. Now, not everybody with HCM is at high risk for sudden death, and there's a number of features, including sustained ventricular tachycardia, syncope or fainting, very thick hearts greater than 3 centimeters, and a family history of sudden death and a family member with HCM. These are the kind of classic risk factors where if you have these, then you're at higher risk, and a defibrillator is very much considered. There are a number of other emerging potential risk factors, such as non-sustained ventricular tachycardia, short runs of VT that stop on their own that are generally less than 30 seconds. The more episodes of these and the longer they are, the more they might have significance. SCAR identified on MRI is another emerging risk factor, as is the burnt out phase of HCM, where the ejection fraction or the squeeze function of the heart starts to drop below normal levels. I mentioned the implantable cardioverter defibrillator, or ICD for short. This is an implantable device that's designed to really monitor the heart rhythm for these potentially life-threatening heart rhythms. And if VT or VF do occur and sustains long enough, the defibrillator will be able to restore normal rhythm. It can either do this by pace termination, meaning it paces faster than the rhythm it's sensing, and sometimes this can terminate the rhythm if it is an organized ventricular tachycardia. If that doesn't work, or if it's just ventricular fibrillation, it will deliver a high energy shock to, again, reboot the heart's electrical system so that a normal can take over again. Currently, there are 2 different styles of defibrillator available. The conventional ICD is one where a wire goes through the veins, and the generator, which is the computer/battery pack, just goes under the skin, just below the collarbone in the left chest area, upper chest area. And this wire goes through the vein into the ventricle, and that's how the device senses the rhythm and is able to deliver its therapies. There's a newer device called the subcutaneous ICD, where no wires are within the blood vascular system. Everything is underneath the skin of the left chest wall. The advantage to the subcutaneous ICD is that nothing is within the heart, nothing's touching the heart, nothing's in the bloodstream. The wires are believed to be more durable and less prone to serious infection. However, these devices cannot pace the heart, whereas the transvenous devices can. Now, which device is right for any individual patient? Again, just like many have talked about already, each patient is different, and this is a discussion with the physician about what the pluses and minuses are of each device. Now, I mentioned ablation can be applied to many different types of arrhythmias. VT is another that can be ablated. As I mentioned, organized ventricular tachycardia is generally due to an electrical circuit within an area of scar. VT is more likely to be seen in HCM patients with what we call apical aneurysms. Dr. Malekan showed great pictures of the apex of the heart. And in some HCM patients, that apex, due to maybe mid-cavitary obstruction, can become scarred and very thin. And that scar area can harbor these electrical circuits for VT. And these circuits can be mapped and ablated with radiofrequency, as I showed for atrial fibrillation. And the catheters, again, are placed through veins and arteries into the heart, but sometimes we need to get to the outer surface of the heart as well, what we call the epicardium. And that can be done with minimally invasive techniques, just like we do the inside of the heart. So on the top here is a display of an echocardiogram showing one of these apical aneurysms. This is the left ventricle. This would be where the valves are here, and this is the apex. On MRI, you can see this thinned outpouching of that aneurysm, and you can also see these white areas, which are scar. And this little arrow here is pointing to a blood clot that can form in these areas as well. This again is our mapping system showing normal voltage in purple and scar in these other colors. This is endocardial or inside the heart. This is an epicardial map or the outer surface of the heart. So we have a lot of different techniques to get to different areas of the heart that might need to be ablated. So that was a pretty quick tour through some of the most common arrhythmias we need to think about in HCM patients. And I'm happy to take any questions at this point.
Jason, is that Zoe's hands? What do you got there?
It's stock from the internet. I don't know what to tell
You should make her do it.
you.
Yeah, that'd be nice.
You could have lied and said it was yours. We probably would have believed you.
I'm constitutively unable to lie. Sorry.
Yeah.
It's a good trait. So we do have a couple of questions. And I'm going to start it off with a setup question as well. So in my experience, as seeing a lot of HCM over the years, left atrial dimension is really a driver of who we want to watch closer for atrial fibrillation. Would you agree with that?
I would agree with that. That is across the board, be it HCM or non-HCM population. So definitely.
We don't talk about those other hearts. We just talk about HCM hearts here.
Sure.
So left atrial measurement is something patients might want to just track to see if they should be a little bit more cautious about screening for atrial arrhythmias.
Yeah.
I think there's not a whole heck of a lot you can do if it's getting, more enlarged, but if you know that there's a risk, maybe we can mitigate it sooner with anticoagulants, et cetera. So Scott's asking a question. What is your approach, this is a complicated one, to managing patients with atrial fibrillation and cannot terminate through medication, cardioversion, or ablation, and they're stuck in atrial fibrillation? What do we do with them?
Well, it can be a combination of therapies. So sometimes it's ablation plus medication. Cardioversion, as I mentioned, only works, that immediate split second. Some patients, despite all efforts, cannot maintain a normal rhythm. There are times when we consider even surgical ablation, depending on the patient and the need for sinus rhythm. Now, there are a few ways to consider this. Sometimes patients' symptoms can be managed by electrically disconnecting the upper and lower chambers, what we call AV node ablation, so that whatever happens in the atria stay in the atria, and the ventricles would then be completely controlled by a pacemaker. Now, this isn't always the end of the story because, like I mentioned, it's not just the fast irregular rate that is the cause of problems with atrial fibrillation and HCM. It's also the loss of atrial kick. But there are times when, despite all best efforts, we can't restore normal rhythm in the atria. So AV node ablation and a pacemaker implantation is certainly kind of the option of last resort for us.
If I can jump in there. So I agree with all of that. And most of these patients are two buckets. One is they've been in AFib for so long that their atria have been remodeled and make it really refractory to all these treatments. Although I think we try really hard here. The second thing, though, and we see this a lot, Jason, and you can chime in as well, is that sometimes patients with HCM and AFib, they go to an electrophysiologist outside of a center of excellence and they get multiple ablations and it's not working. But the truth is they never address the underlying problem of why the atrium is so refractory, which is how do you improve the overall heart function?
Right.
If atrial pressure goes down, regurgitant volume goes down, mitral leakiness of the valves goes down. So oftentimes those patients, they've had 3 ablations, they come to us, they may get a myectomy or an alcohol ablation, and then if they continue to have AFib, now it might be more successful because you've eliminated the driver. So that's another thing to consider in some of these patients who are quote unquote refractory.
Absolutely. And, I certainly have that luxury of, being at a center of excellence where I know all of those things are being considered, but that's an excellent point. And, Lisa, to your point earlier, and thanks for reminding me, Hari, I did want to mention that watching the left atrium is basically kind of the bellwether of what's going on in the ventricle. So if you see that atrium just continue to be stretched out and get larger and larger, that's an indicator that the core of the problem, which is the HCM, is maybe requiring additional therapies than what's being used at that time. And, anticoagulation, as of right now, we don't start anticoagulation unless we see atrial fibrillation or potentially for an apical aneurysm. But we are pretty aggressive about monitoring for AFib. I think it's important to realize that about a quarter of patients with HCM will have AFib clinically. And then patients who have devices for whatever reason, another quarter of those patients will be noted to have atrial fibrillation that they're unaware of. So it's certainly a large issue and requires frequent monitoring, and that's kind of our approach.
There's a newer, not frequently used technique. Some refer to it as convergent therapy.
Mhm.
Can you speak a little bit about what that is? Is it
So
something that you guys are doing?
So there are a number of techniques that employ both surgical and catheter-based ablation. They're called hybrid approaches, convergent approaches. There's many different ways to do it. Some centers will start with a surgical approach and then touch up with catheter ablation what's necessary. The convergent approach specifically is a term used for a minimally invasive epicardial approach by the surgeons, where they go in with their tools and do ablation across the posterior wall of the left atrium, and then immediately go to the EP lab, where we go from the inside of the heart and finish things off. We are not currently doing that. We have done some in the past. We didn't find it to be as effective as we would hope it would be. I think patients who are going for myectomy and have atrial fibrillation, a surgical ablation approach is definitely a consideration. We've been managing most of our AFib with catheter-based technologies, and in the past 10 years, the tools and the techniques have certainly evolved in a way to make our lesions more transmural and durable. The other thing of interest is, with all these different targets that we talk about, study after study has shown that really primarily start with the pulmonary veins, isolate those, and then see what happens. And so many studies have now shown that all these other targets, if you do that's what we call empirical at the outset, doesn't do it.
Okay, I have a follow-up question here, and that is, in patients who've had a myectomy and the left atrial appendage has been removed or clipped, who then develop atrial fibrillation, must they still be anticoagulated, or what is to reduce which is somewhat reduced due to the absence of the left atrial appendage? So does just having a left atrial appendage clip or removal save you from a lifetime of anticoagulation if you're AFib?
It can. The one word of caution is that I believe that, everybody who's had their appendage removed surgically, not knowing every surgical approach and every surgical center, I like to get some sort of image to confirm the closure and the full closure of the appendage. I think current technology, and Dr. Malekan, I know, can speak on this a little bit as well. I know the AtriClip is, a very good option surgically. I know going past the past few decades of left atrial appendage surgical closure, the different techniques have had variable success rates. So I think it's important to make sure that the appendage is fully either oversewn or removed or obliterated. The best of techniques, a little stump can be left behind. So I think it's important to get some sort of imaging, transesophageal echocardiogram, or CT scan to confirm that it's been closed adequately. And then, yes, I think it's safe to stop the blood thinners.
Fantastic. Okay. Well
right.
done. And let's get rid of that
So Jason,
slide.
you can unshare. I'm going to put up our screen again for the final.
I
talk.
got it. So you've got your team there.
Yeah, I'm going to go to their slides.
You'll be quizzed on everything
Okay.
that just flew through the screen.
Here we go. So for the final talk, I really want to introduce our team. The truth is, we as the directors of the program, it doesn't happen with just us. We are the ones who are looking at the patient, making some of these decisions about how to take care of them clinically and doing some of the procedures. The truth is, all of the parts that make our team special is really the people. So I have three of us here today: Mallory O'Shea, who's our main HCM coordinator; Carolyn Steinmetz, who's our nurse practitioner; and Nicole Goldman, who's our coordinator in Long Island. And they're going to take you through how we put the patient at the center of care, which is really, I think, one thing that's very unique about our program that we're very proud of, honestly. So I'm going to leave the podium.
Hi. Okay. Hi. So we're going to go over a little bit of what goes on behind the scenes and making sure that you're getting the care that you need when you come to the Center of Excellence. Here we are. So it's my job as a coordinator to obtain records, imaging, anything that you might have had leading you up to coming through our doors. So that might be past echoes, MRIs. If I can get images, I do. Anything that I can get to facilitate and pave the way for you to have a constructive and an informational visit with Dr. Naidu. And it's about learning about who our patient is as much as the disease. So I try to put all that together so it's as seamless when you walk through the door as it can be when you're faced with the challenges. So that's a big part of our program. We're going to set you up with an HCM protocol echo. You're going to have a consult with Dr. Naidu. You have that on the same day. He himself goes over the echo. You don't have to wait for a report or results. He's gonna, while you're walking from your echo into our office, he's looking at your echo and going through those images so that he can have that conversation with you. So after that, you come up with a plan with Dr. Naidu, and it may need some follow-up scheduling for maybe more imaging, maybe some procedures. We're going to schedule that. We're going to coordinate that, and we're going to try to make that as seamless as possible for you as well. After you have your visit with Dr. Naidu, whether it's the first visit, the second visit, the fifth visit, we communicate with the referring provider who sent you to us, whether that is your primary care, another cardiologist. We're going to fax our office note over, any of the testing you had, the reports, and we're going to make sure that if we referred you to a neurologist or genetics or a pulmonary, we're going to make sure that our note goes to that doctor so that they know why you're coming through the door to have a consult with them. Again, it's about paving the way so that you're getting the care that you need and your questions are being answered. We have a telephone number that is just for the HCM program at Westchester Medical. We have email. You can text that phone as well. It is a cell phone. It is a busy phone, so I just ask that if you leave a message, I will get back to you, I promise. You're welcome to email me. You're welcome to text me. If you have any questions after your consult with Dr. Naidu, you are welcome to call me the next day and say, you know what, I thought of 10 other things. Can you help me? I'm there. I can answer just about anything after 7 years of doing this, and what I can't answer, I will find you the answer. So I'm always happy to return that call, to answer those questions. We are always going to be there for our patients and hopefully make you as comfortable as we can as this process unfolds in front of you. So that's what we have. And with that said, I'm going to give you Carolyn Steinmetz, our nurse practitioner, and she will go over a little bit more.
All right, so something that's unique to our program is that we really guide our patients through their outpatient and diagnostic testing. And so that starts with the pre-admission appointment. Every patient will have one of these appointments prior to testing. And at that appointment, we go through the procedure, the risks, the benefits. We do any pre-testing that is required, such as labs and COVID testing, x-rays. And so the patients really leave that appointment feeling informed and ready for their procedures. And it helps relieve any anxiety that might come with any of these procedures. So the next step is coming in for these appointments, and usually are the testing, and usually we try to coordinate the testing so there's multiple tests on the same day. So patients will often have like a cardiac cath followed by an MRI or a transesophageal echo. And this is to, minimize your trips back and forth to the hospital. When patients have tests, our whole team knows about it. We know that you're coming in, and we're prepared for you to come in, and we're ready to help you guide you through the day and make sure things run as smoothly as possible. Then at the end of the day, Dr. Naidu and myself will meet with you and give you a plan. And if that's medication changes, we're calling in the meds to the pharmacy that day. We're arranging any subsequent follow-ups. If the plan is to refer you to another specialist, we can usually arrange for the other provider to see you that day while you're at the hospital. Again, minimizing visits back and forth and trying to make, the day as, important and successful as possible. So if you find that you're a patient that's in the hospital, we do a very good job, I think, at treating you. So any cardiac problem, if you're a patient that has HCM and coming in with a cardiac problem, you're going to be on our HCM service. That means that Dr. Naidu and myself are the primary care team, and we're taking care of you during your stay and coordinating your care with other services that might be involved in your care. If you come in with another non-cardiac problem, Dr. Naidu and I are consulted. And so we're working with the primary team to make sure that you're getting all the cardiac care you need during your hospitalization. And so this is very important for the patient, because when you come back to us as an outpatient after your hospitalization, Dr. Naidu and I know exactly what happened during your hospitalization because we were there. So this is very unique to our program. Also, if you happen to find yourself at another hospital, we will coordinate care with that hospital. So we will usually call the doctors at the outside hospital and coordinate care as well to make sure that you're getting the medications you need. And they often will, be happy to take our advice. We also have cardiac fellows who come through on an HCM rotation. So a fellow is a cardiologist in training, and they're very important to our care team in helping you get the best care possible while you're at Westchester Medical Center. And so something else that we started this year is the CMI clinic. So the cardiac myosin inhibitor, which is the new class of medications such as Camzyos. So we have designated clinic times and echo times for these patients, which is very important because the REMS protocol for these medications is very strict. And what I mean by that is that every patient needs an echo and an appointment every month for the first 3 months in order to continue to receive medication. So we designed a clinic that ensures that patients will always have these echoes and appointments so that they don't miss any doses. And this took a lot of coordination, but it's worked out wonderfully for all our patients on these medications. Furthermore, we've had a lot of experience with getting these medications approved by insurance, and we haven't had a single patient where we weren't able to get these medications approved by insurance. So this has been a great addition to our program this past year. And so with that, we're on our last slide that Dr. Naidu would jump in for.
So you got a little sense of the team here. And I think hopefully what you get a sense here is that we have a family of people taking care of our families, which is really a team approach. I think we have developed expertise in all the areas we discussed. You saw a little bit of sampling of that today. I think our physicians really have seen hundreds, if not thousands, of these patients. And so there's a lot of experience tied to expertise and how to take care of the patients. And that goes for the team here as well. Nicole's been with me 14 years, Mallory 7 years, Carolyn 3 years. But with that, we've had a very robust program that allows us to take care of patients in a way that they know they're being taken care of. They're always seeing only people who know them, whether they're inpatient or outpatient or just calling in. We're the main people they talk to, and we make sure that no mistakes happen because we kind of keep everybody else away, and we make sure that we kind of decipher everything the patient needs. And we have a lot of fun. Even though it's late tonight, we enjoy doing all of this and making sure that our patients get what they deserve. So I'm going to stop sharing there. And then Lisa, I think that's towards the end, but feel free, any questions you want to ask the people on the call now.
Ask questions now or forever hold your peace, or until the next Bighearted Warrior tour, which I will be doing from another hotel room, but on another coast. I will be in California for that one. We did have a comment from Scott again, and he said, I want a program like that where we are, where it's cohesive. And I told him I'm trying to work on it. The Southern California area, LA area doesn't have the same continuity of care as some other parts of the country. So I'm working on it. So I wanted to just take a moment as we populate some questions, I'm sure from either Facebook. I actually did cheat and I told Facebook people that they were allowed to ask questions. I don't know if they're going to or not. They're not used to that. But I just came back from the American Heart Association conference. I was going to try to podcast tomorrow with some updates, but unfortunately this hurricane that's coming up the coast has forced me to get on a plane very early.
Yep.
So I will not be podcasting tomorrow morning because I'll be on an airplane instead. But oh my goodness, people, the American Heart Association, I've been going for over 22 years, but I've attended 19. That transplant thing kind of sidelined me for a few of them. But I wanted to let you know that this is the first time ever in the history of hypertrophic cardiomyopathy that HCM actually appeared in the Heart Hub, which is like the center Big Mac Daddy area for the American Heart Association. And HCMA AHA co-branded material was at the center of that booth. It's a different day. People are talking about HCM all over the place. Our centers are going to get busier. We are going to need more resources in terms of staffing to keep up with everything because we're growing. And I see Hari looking at his team there going,
They're scared, busier.
We're going to get busier. I just saw that look go. I didn't know she was going to say that, but things are getting very, very busy throughout all of HCM. Clinical trials are coming fast and furious. They're coming from angles that we didn't quite expect before. The conversations are changing. So it's really a good time to have a bad diagnosis like HCM because we have more treatment options than ever. When Hari and I first met, it was myectomy or ablation or beta blockers. And that was pretty much what we were relegated to. The FDA has opened up a new pathway for something called real world evidence for medications that can get new labels without big clinical trials. So there might be hope for things like Norpace CR should be made available again at a different level with production limits that won't make us go to outage. There's new drugs coming. There's new genetic therapies coming. So I encourage anybody who's watching this to get in touch with their local HCMA recognized center of excellence. If you're in the New York metro area, you've got lots of great options. And we are a community. We're going to have slightly different opinions on things and different, mannerisms in which each practice runs, but you have options, people. Use them. They're amazing. I don't see any other questions coming in here tonight, which means we did an excellent job and answered everybody's questions. But I am going to take a moment and turn off the Facebook feed and turn off the recording and give everybody a few moments if they have a question that they would like to ask and not be kept forever in the internet. So on that note, I'm going to say goodbye, Facebook.
Goodbye.